All right, here we are back. This is Senate Health and Welfare, and we're moving on to H 536, and we have folks in to give us some, I hope will be the final testimony on the bill. So, Bill Pearson is here. This is the toxic things.
Okay, thank
It
you.
could be clean.
Well, what I'm going to talk about is very clean.
Okay.
Thank you, Madam Chair. It's good to be back again with this session. Dr. Stoll with Associated Conditions in the Fund. With regard to 536, our primary concerns or recommendations are not with the underlying bill or sort of those introduced when it comes to the label and testing label with baby food. I mean, there's general industry support for provision of the bill largely because it reflects what's already been adopted in a number of other states. They adding up to over 60 million people in terms of population wise. So you have that sort of market mass where industry's going ahead. They'd be doing that in a more uniform way. So no concern with that. Where we do have some concerns and recommendations are with regard to including infant formula in the bill. There's I think there's sort of just very general overviews of those concerns, and hopefully you can hear from the industry folks on more specifics, and also happy to follow up on that as well. I think to begin with, I think it's important to keep in mind that infant formula is regulated much differently than baby food. So much more strictly regulated, not only what can't be in it, but what has to be in it. And with regard to heavy metals, it's my understanding that the European Union standards that the already has to meet are fairly strict in that regard. So I'm sure that there's some concern about the heavy metals and the proposal per se. Beyond that, however, there is some concern about if you're going to be having labeling about heavy metals in the formula, that context is very important and the consumer understanding of what the numbers mean important. With regard to baby food, there's an extremely large diverse universe out there of different baby foods. Infant formula, the universe is much more narrow and small, and the impact of suppressing the use of infant formula or scaring people with information about heavy metals is not about context or understood. You have credible substitution of formula, which can be an issue. And I think you also much more how to affect in the lower income programs as well. Beyond that, on more practical levels as well, no other state currently requires this. So it's a very different environment than we have for baby food, where it's already pretty well established in the market. I think Maryland, but so in the states that have adopted baby food testing and label requirements have explicitly excluded infant formula. I think some of the reasons that's specified, which you can also hear more about. It was a proposal in Maryland, which I think has been put aside, so that's not going to be expanded beyond baby food. I think the issue is still alive, perhaps in California and New York, but it's part concerning whether they're doing things changes beyond what they had originally enacted. So there's some concern about Vermont being out there either on its own or a sort of small part of the market to require it. But also beyond that, the FDA is actually currently looking at making recommendations with regard to heavy metals. Your initial report is actually technically due this month, which the government report should have not checked with about the timing might be. But they are in the process of reviewing and potentially making recommendations which would provide a lot of context and guidance that would actually help and tailor this kind of requirement for the context, which is not currently available. So all that kind of leads to like a primary recommendation, frankly, would be to follow what is in effect in the other states right now and continue to exclude the formula for now, but certainly be ready to come back next year after the FDA has taken some action, the other states can take action and sort of see how they have approached, first of all, what they require and recommend, what other states have done to interpret that. And then much as like the underlying bill that's baby food, include Vermont then in what those other states have been doing. Alternatively, if there is going to be a trigger for action, we would have some recommendations on making changes to this and the bill's decision based.
Yeah, right.
I will follow up on this. It's fairly important. Whenever you have a population figure, obviously, Vermont has either included or considered population figures for a number of issues. Certainly a lot of the chemical and other regulations that we talked to this maybe about in the past. We'll talk about in that context. But there are three elements that are important to really think through. The first one is what level of the trigger should we have? Like how many states or how much population? And generally, these things are done in population, not in specific states. The second element is what level of uniformity among the states do you want to have to make sure we require? And the third is what is actually triggered? Whether you have a pre-vague statute that just goes into effect on a certain date, or whether you require a report of recommendation as to what you should do once you meet that trigger. And depending on how you do the first and third, either how high you have to set that trigger level in population, or whether how pre-baked or how much you look toward recommendation in terms of action, those two things kind of interact with each other in terms of what makes a prudent and useful way forward. The higher you set the trigger, the less important the third element is. The lower you set the trigger, the more important it is to not bind your hands and end up doing something that kind of sets you up for it. Sure.
I haven't looked at this bill in a while, so can you orient me to what you're talking about population triggers?
Sure. So I don't have there's a section toward the end of the bill that on the day it's introduced or on enactment, the bill does not include infant formula definition. It then says that if California on its own or two other states enacts essentially something substantively similar,
Oh, right.
then it'll go into effect.
So that's what you're calling a population trigger.
Yeah. And certainly California on its own can move markets. It doesn't always move markets just on its own. But for any two other states, without regard to how large those states are or whatnot, that I don't know if I've ever seen a trigger that low when these sort of mechanisms have been discussed and other issues in the past. And so we would have concerns about whether that would put us in a situation where we're locked into this requirement and it's really not very pervasive in the market institutions. There's a number of other states doing it, and there's all sorts of complications that result from that. So sort of twofold, if you're going to have a trigger, I don't know if I have a magic number for you. I mean, if you look at baby food, where there's really is no concern about adopting what there's done, those states encompass I think 63 million people. So it's like certainly 60 million would be a reasonable threshold for the market. Where there has to be that high, we can follow up with you about that. But
So,
it's really more, yeah.
now this is, I understand what you're saying is you'd like to see infant formula put off and have a different level, trigger level than what's currently in the bill.
Mhm.
If you could send us your comments in writing, that would be very helpful. And we're very short on.
Yeah, I'll wrap up
Just so,
very quickly.
go ahead.
Because we have so many moving parts, it'll be us. I think it's more important that what is triggered is whether it's the AG or health or both, that they're required to come back, tell you what has happened, and make recommendations what we should do, rather than have something that just is on the shelf and just takes. That's the main thing. There are other little things like some of the sell-through dates, some of the little details, which would also need to be updated if you go ahead with the thing here. It's right now, the bill locks in a sell-through date for baby food, but it doesn't update that for you later in the formula. So things like that. You can follow up with that.
Understood.
Yeah.
So, and as you said earlier, however, there are very few manufacturers of infant formula. Not like,
Right, and I think if you look at some of the, well, I don't know about some of the low income programs to speak, but I think that people with me too in terms of short significant.
questions for Bill.
Well, I mean, what will happen in the market if the FDA makes any recommendations for infant formula? They're all gonna have to pivot or, do some creative modifications to what they're.
Well,
doing.
I would expect, I mean, I guess we don't know. I don't know that the FDA might be expected to be more strict than the EU. So I don't know that the manufacturer will necessarily have to change anything, but it will at least give it a context for them to present, both test and present that information, what this really means. This is, in according to the FDA or below FDA. But again, we don't know exactly what's going to be required. So that's part of also, maybe know what the context is before we lock ourselves in on a path.
Thank you. Good. So, we have a tie from the AG's office. Welcome.
Thank you.
Do we have your testimony, right?
No, but I'm happy to
Make
provide.
sure we can. For two. Excuse me. And this isn't for you, it's for everybody who testifies in this committee. If you have your written testimony ahead of time, things can move a little bit faster along with time for more discussion. If you don't have that, it makes it more difficult. So that's a general comment that in Felicity usually she always sends it out. Which is good. Anyway, thank you for being here.
Thank you for having me. For the record, Todd Bailey is Assistant Attorney General. I will be brief given the short amount of time and a couple more folks after me. The Attorney General supports this bill, supports efforts to protect the most vulnerable consumers in Vermont. I think the bill goes a long way towards providing consumers information, which is one of the most important consumer protection mechanisms. I think most folks would consider even just the title of this bill. They would be surprised that we need to legislate to keep heavy metals out of baby foods. And I, as a former parent of tiny children, appreciate that. And as somebody who advocates on behalf of Vermont consumers, I certainly appreciate the efforts of the committee and the House in working on this. I would say that the Attorney General also strongly advocates for the inclusion of infant formula. I think in some ways, understanding market pressures that are to bear and the argument that zero infant formula is likely better than lead-based infant formula, we still would advocate strongly to ensure that Vermonters have access to infant formula and pressure increased on the market to prevent infant formula from having these toxins in any significant amounts. That's the crux of the testimony. I think I had one small requested change and one sort of question request. I'm happy to touch on, and again, can provide these in writing fairly easily. The first requested change is on page 5.
Hang on a second. Okay.
Lines 12 through 16 are sort of the standard language that is a crossover reference to the Consumer Protection Act. We have been requesting, when this language was used, just to cut on line 14 through 16 the specific reference to the authority. All that authority is already laid out in subchapter 1 of chapter 63 of the VSA. So suggesting we cut from the word to on line 14 to make rules, conduct civil investigations, enter into assurances of discontinuance of principal actions of private parties have this, I guess, we would continue to add in private parties. But listing our authority under chapter 63 suggests that it's not in that list. We don't still have that authority, and we don't think that's generally the legislative intent. The legislative intent has traditionally been just that we act as the we would under any consumer protection violations.
So I want to be clear with what you're saying. So on line 13, you're saying, in the beginning of the sentence, it says the Attorney General has, and then ending with subchapter 1 on line 16 to cut all of that out.
No, sorry, I'll provide the language.
Yeah,
This is
that's
not
fine.
also
But
the
then,
language.
okay, good.
The final reading, as we would suggest it would be, the Attorney General has the same authority, and private parties have the same rights and remedies, as provided.
Got it.
And then the other is just a question, and it's related to section 2 on page 6. What would become the new subsection G? And this is about the AG, verifying that there's sufficient information in the state to meet need. We don't have an easy way to do that. And it probably makes sense for us to consult with some folks who may. I don't necessarily have recommendations on who that would be. But I'm sure there are partners within the state, and there may be industry representatives who could be helpful for us to consult with and make that determination.
Guess the balance I'm trying is when there was a shortage of babies, things were not, and if get the price at a level where people can't afford a formula, we could be creating a system where parents need water it in order to do babies, and it strikes me as you want to make sure baby formula is healthy. Babies have been on formula for generations. Metals are bad, but I don't. I've never heard any testimony that there's actually harm being done as opposed to the harm of not having access to fluoride. And I think that's just right. And I want to see us create a place where babies are going hungry. Well, parents are going hungry, so babies don't.
And I think, Chair, not to interrupt.
So please,
I think Senator, in a past role, I was certainly involved more in a recent shortage, and I would certainly defer to the health department to talk about, informing the recall several years ago, how the state was involved in that work. That would provide, that's a safety recall. I'm not saying that's this level, but I would say there are opportunities to ensure coordination and communication around this, and I think it's a wise legislative choice to create this gate or a means of providing, ensure that the market is ridiculous. I would agree, zero food is much worse. So we'd be open to whomever you would suggest. We may do it anyway, even if you don't put someone in statute.
I think, we're not experts on who you should contact either. There are some, we may be hearing from one in a minute. But it certainly would make sense to reach out to understand. Yeah, but some language in yes about what's intended. The big problem, that's right. Good, thank you. And make sure you send us especially the suggestions for changes that you have. Thank you.
Thank you.
All right, and so we have Tom Nelmer here, National Director of Unleaded Kids. Welcome.
Thank you. I appreciate the opportunity to talk to you. I submitted written documents last night, so you should have those. To
Yeah.
be brief, I'm going to focus on some of the key issues because you've already heard some excellent analysis of the options and issues. I am, again, a chemical engineer, a lawyer. I've worked on lead poisoning prevention for 30 years. I've worked on food chemicals for 15, and I've been working on lead and heavy metals in food for the past 9 years. So this is an important issue for me. Let me just explain two things that make this bill in Vermont important nationally. One is it closes a loophole that we've seen in the other bills where a company's webpage for their product doesn't tell you that there are test results available. So provision D2 regarding baby food products says you need to, on your product webpage that details the product, needs to tell people about testing results. That's been a source of some frustration for parents out there. I think it's on page 9 of the version that passed the House. I'm not sure which version you have, but it's D2 right before paragraph E. The second one is it deals with infant formula by bringing it in a thoughtful way. I'm working in California on the bill. The California bill is poised to pass the Assembly. It just has one final checkoff to go, and then it'll be considered by the Senate. When I work with those folks in California, the legislators ask, what's Vermont doing? So Vermont doing it gives additional incentive, additional support for California to do it. If California or Vermont were to remove that provision entirely, it would be a signal to California that Vermont's not supportive. In some ways, that's what happened in Maryland. So I'd encourage you to keep it, but refine it the way that you think's appropriate. Why is this bill good for Vermont in my perspective, since we already have this in other places? And that's because it empowers the Attorney General to make decisions about including infant formula, but it also gives clear authority for the Attorney General to be able to take action and demand that the companies submit the information. In my experience, I do not know Vermont's Attorney General authority, but it helps to have that clear statement that the Attorney General can request that information, and then the Attorney General can answer some of the questions, because we do want to make sure not only that the testing results are publicly available, but that they're accurate. So there's ways to double check that. Those are my reasons for supporting this bill. I appreciate your deliberations both in the House and in the Senate, and available for any questions you may have.
Questions, committee? Well, we have an expert in the room.
Yeah,
Rather.
thank you so much for your testimony and for being here. I'm wondering if you heard the discussion about baby formula, and if you have any thoughts on how to handle that.
I think it's really important, especially since it's in the House bill, to keep it in and then find a way to make it work for Vermont. I am pretty confident that California will pass. So some of those nuances are reasonable. I would love to see Vermont include infant formula with the option for a suspension. But those are really, I'm not from Vermont, so I don't think it's appropriate for me to weigh in on that. But what we've seen on baby food is that when you do this transparency, parents are more confident of the information, that they see it and they trust it. It also, they know that safe isn't a bright line. What it is they know that less lead, less cadmium, less arsenic, less mercury are better things. So some parents will look at it. More importantly, for those companies that are trying to reduce those levels, it gives them an incentive to do better. It opens the playing field. On baby food, we went from about 10 baby food companies in the national market to 39. And that reason was because they felt that they could compete on this. It was more than just price and nutrition and brand name.
Thank you. Any other questions? Your market expansion.
Yeah.
Okay. So thank you for being available. And has Prop 65 taken this issue up in California, you know?
I'm sorry, what, I didn't understand your question.
And do you know if Prop 65 has been discussing it?
No, Prop 65 exists outside of this. This is,
Yeah, I know.
Transparent.
I was
Okay.
wondering if they've taken up the issue at all.
but they do have standards for these, for toxic elements. But it's, they're distinct processes. And it's the lot by lot public testing that just transforms this marketplace.
Okay, thank you. All right, good. All right, so we have Julie Arrow, you're right here. Wow, thank you for being here.
Thank you.
Why don't you introduce yourself for the record and then go.
Yes,
Well, we've got your testimony, this is great.
yes. For the record, I'm Julie Farrell, Deputy Commissioner of the Health Department. And I'm joined by my colleague,
Hi, I'm Andrea Kirk, I'm state toxicologist.
just in case you have any technical questions that I am unable to answer. I'm gonna go through quickly. I know you're very short on time, so I won't be going into a lot of the detail that I originally planned to, but you have the slides that include the information.
I think you heard the question earlier about, well, it children's health and others are doing, so working with kids.
Yes. So I'm going to skip over the second slide and just move right into slide 3. I'm going to go quickly through them. I'll be talking in more detail about the health impacts of arsenic, lead, mercury, cadmium. On slide 3, really, the important thing to know for this is that excessive exposure to inorganic contaminants and food impacts all humans, but it disproportionately impacts children. And because of their immature development on their eyes, food intake body weight ratio. So moving on, talking about arsenic, and it feels almost silly to be sitting here like arguing, not arguing, but testifying about and talking about arsenic and cadmium and lead and food. But it is important to know what their impacts are on the human body. So arsenic exposure impacts multiple organ systems. The most severe effects being damage to the central nervous system and cognitive development in children. It can also alter their neurodevelopment, leading to impaired memory, learning problems, and behavioral problems, leading to increased risk of cancer, and can cause birth defects. And it's important to note that Vermont does have in areas of the state arsenic in well water. So there are people that are already being exposed to arsenic in their well water. Moving on to lead, I think we all know that there is no safe level of lead in the body. Even low levels can impair development in children, hurt their brains, kidneys, and nervous systems, slow down growth and development, making it hard to learn, damage hearing and speech, and cause behavior problems. And there have been studies that have shown that children with lead-associated developmental delays show persistent cognitive deficits into adulthood. And again, many children in Vermont are already exposed to lead in their home. So these are cumulative. If they're getting it both through food and other sources, that's an area of concern. Mercury is toxic to human health and poses a particular threat to the development of children in utero and early in life. Even low concentrations of mercury can have harmful long-term health effects. It's a neurotoxin. It impacts the central nervous system, kidneys and liver, hearing and learning, movement, coordination, and heart function. Cadmium is a human carcinogen, which accumulates in plants and animals. And one of the major routes for cadmium exposure in humans is through rice consumption. And that also holds true for some of the others. It's important to note that rice is a very common ingredient in humans. cadmium in children's bodies can alter their brain development and infancy, negatively affect IQ scores. It's linked to an increased incidence of ADHD. And both the liver and kidneys are extremely sensitive to cadmium's toxic effects. So in conclusion, reducing heavy metal exposure in infants and toddlers can help to improve pediatric health outcomes. Heavy metals affect all of the health impacts of them. And it's really a child's total heavy metal exposure that is the greatest concern. So reducing them in baby food can help to reduce overall exposure and health impacts. I'm happy to answer any questions you may have.
There's rice.
That was my question.
So, yeah, I skipped over the slide that may have provided some information. So, these heavy metals, all of them occur naturally in the environment. And it varies based on geological formations. And then in the production of some of the foods, the use of the water or the production of how they do it, that can all introduce, as well as pesticides, can also introduce it. I'm not exactly sure. Are you able, Andrea, to speak to why rice in particular?
I think rice is very able to suck heavy metals out of the ground and water that it's growing in. So you have higher cadmium, but also higher mercury and arsenic.
But so Ivan also grows in a watery, very watery environment, so I know in the water. You just ruined.
I know. So, yeah.
Is there organic, right? I know there's a rice grower in Chittenden County. I think.
Yeah, no, it wouldn't matter for the
Doesn't-
heavy metals.
Wow.
Because it comes from the soil, the air, the water, so.
Definition of organic is different.
Right.
I mean, you may have not added pesticides, but
Right.
it could still be absorbed up through the soil.
So,
I know.
so I'll ask one question.
Environmental health walks in a room and everybody's, need anything?
I think arguably, surely there are parts of the world that have lower concentrations of mercury in their groundwater, in their groundwater, right? I mean, it's, no, okay. Wow. Okay.
So is there, how many of these accumulate in the body over time? Obviously, lead is one of those. Builds up, are any of the other heavy metals similar to that? Right.
Methyl mercury will accumulate, obviously lead, and cadmium. Cadmium tends to kind of concentrate in the kidneys. And arsenic does tremendous oxidative damage, but it also tends to be excreted relatively quickly.
So it's okay to drink your arsenic.
No.
Not if you're drinking it every day.
Yes.
That was a facetious question. Okay. All right, any other questions? for the Department of Health? Thank you. Thanks for bringing.
Thank you so much for having us.
All right. Well, we are actually not too bad in our timing. I will say, committee, that I think the next time we look at the bill, it will be helpful to have any of your thoughts. If you have thoughts now, I need to know. We could share with Katie regarding any changes we'd like to see. I think the AG has brought one. Bill Driscoll got a suggestion for extending the trigger. So think about that. It could be simply a timing. For me, if California passes something, then the trigger is automatic, or is it a date certain after that we could look at as a state? So that's how I would look at that one in particular. And I think the next time we come back to look at the bill, we will be able to complete markup on it, so we can vote. It's an important bill. It's important for kids. All right. Thank you all. Thank you for being here. Appreciate it. Jesse. I'm good, I'm good. I'm good with what we, yeah, what it is. Okay. Right now. Okay. Now, at least for now, my mind major game. So Daisy is here. Daisy, thought you were peeking. Yes. I thought mine is so. Oh, your assistant.
You want to sit there? You want to sit here? You want to sit here? Is that okay with you, Madam Chair?
Absolutely fine.
Okay, wonderful.
Wow.
As long as you can introduce yourself.
Okay, you're gonna have to say my name. Okay. Because of the. So that you don't. Okay.
So
Yes,
we say welcome and what is your name? That's a beautiful name. Thank you for being. And you're awesome. And we're very happy to have your mommy here. She's very special. You're very good.
Thank you for letting us join you to talk about H817. Daisy Rebecca. I am Vice Chair of House Healthcare Committee and author of the bill. I'm gonna read a bit from my full report.
That would be fine.
Okay.
So we don't need the whole thing, just what it is, what it does.
And why, and why. This bill promotes youth peer-to-peer support programs, and it aims to improve how adults who work in schools recognize and understand youth mental health issues. I'm gonna list some data about Vermont youth mental health just to demonstrate one reason why we need this bill. And I'm gonna apologize in advance for sort of the dark news, but there's no way to really sugarcoat this, as you all know. Suicide is the second leading cause of death for 10 to 14-year-olds in America. And 1 in 4 high school students in Vermont report doing something such as cutting or burning themselves to hurt themselves on purpose in just the last year. 1 in 15 reported trying to kill themselves at some point in the past year. 34% of Vermont high school students said that their mental health was not good most of the time or always in the past 30 days. And only 1 in 5 high school students in Vermont reported that they haven't experienced poor mental health that much. So our kids have told us that only 20% of them can go 30 days without having a mental health or without experiencing poor mental health, including stress or anxiety or depression. So what have we done as state leaders to really respond to that lately in a meaningful way? We know that healthcare in Vermont is the most expensive in the country, and that we also have some of the highest property taxes. The majority of our mental health workforce would probably make more money working at McDonald's, in part because our state budget for their services just isn't keeping up with inflation. A therapist makes 62 cents to every dollar earned by a physician assistant. So recruiting and retaining enough mental health workers in our state is a huge problem, and one real world impact of that is that when a Vermont academic, sorry, I lost my page.
Sorry.
So I'll just talk a bit about some of the programs that are already operating peer-to-peer programs for youth in Vermont, because this is happening around our state already, just not in a real structured and meaningful way where we can sort of gauge what's working and what isn't working. Mentor Vermont has a DREAM program. Cambria's brother participates in. Vermont youth are paired with slightly older peer in that program, and so that they can sort of have a role model to just talk to one-on-one. It's very unstructured, right? But the older students go through a month of training so that they know how to work with the younger kids. Vermont After School also has several youth peer-to-peer programs that we in House Healthcare have a lot of youth come in and talk to us about, and I would encourage you to invite in some of those kiddos. I know Hartford Unified School District is working with several of those programs to great success. I want to highlight that this bill refers to grant programs, but it does not carry any money.
It also addresses mental health, but it doesn't have any clinical services. The activities are really directed at school-age youth, but it doesn't outline any specific curriculum. That's because this legislation is different. It's really aiming to get upstream for us. It embraces successful age-appropriate components of the existing programs in our state, like Mentor Vermont and Vermont After Schools programs. NAMI also has several great programs that are free that do this work. I think one question we're asking ourselves in developing this is how can we keep these resources relevant and accessible to youth, their families, and our teachers and staff in schools importantly. This legislation is intended to build upon the past investments that we've all made, the strength of the protective factors for our kiddos, their teachers, their families, and also for our economy, given our workforce challenges. What we're hearing consistently about youth mental health is this. We need to build stronger connections earlier. We need to equip school communities with practical knowledge and create safe, structured ways for students to support one another without replacing professional care. And that's what this bill is designed to do.
Thank you. So, you bring to mind the work that we did with the ERA funding and between the Agency of Education and Department of Health. A few years ago, with $3 million and to have schools working with Department of Mental Health on this kind of program. We've never looked at the outcomes of that. So I'd like to look at the outcomes of that. Maybe add something in there that would have that report done. Because what you're suggesting is an ongoing process and set of programs that we can get our arms around that touch every kid.
That's right.
In schools, probably the best place to be.
That's right. And it was really incredible, the response that we got when we started taking this bill up from youth across the state. It was incredible. I had no idea they were paying so much attention to us, but they absolutely are, and so are their teachers. Yeah. And there's already great resources in our state that are Vermont specific to how to work with youth, how to recognize signs of mental health challenges, behavioral challenges early on without needing that clinician. And so that helps keep our costs of healthcare low and gets upstream on things.
Totally important in the area of prevention. And as I recall, what we did put in, I remember the whole grant process, yeah, which did include community members and outreach to local municipalities, schools, and others. So this is a continuation of this thing. So we'll look at the bill. And great, sorry, we have a question.
I just want to say thank you, Representative Rebecca. This is a complex and sensitive area, and there's a lot of hand wringing and people trying to figure out the best approach to help young people. So I really appreciate you taking action. Take a step forward and quantifying this. Thanks.
It's pretty simple. We just listen to them. They just want to talk to each other.
Yeah.
Just give them space to talk to each other, and this can be an on-ramp for whatever
This is
potential
what
funding
starts things, right?
future days might bring up.
Relationships and communication.
That's right. Connection.
Thank you.
It's good. Anything to add, Andrea?
So I don't know.
Thank you for having us. Oh, yes. Are you a good fisherman?
Terrific.
She
All right.
really is. Thanks so much for having us.
Thank you for coming in. Katie's gonna go through already.
Have a good vacation. You too. I wish.
She said you too.
Yeah.
Katie, can you walk us through the, and we'll move from that one to 816.
Greetings. Good morning.
Good morning.
Caitlin, Office of Legislative Counsel, in Chair Nice Week.
Here's 817. Fairly short bill, so most of my work has already been done for me. This adds a new section in Title 18 in our mental health chapter. So first we have a purpose section. This section aims to strengthen protective factors among Vermont's youth, increase mental health literacy within school communities, and expand access to developmentally appropriate peer-to-peer initiatives that promote early identification of mental health challenges. And then the next two sections each develop sort of separate programming. So the first is the mental health literacy training, and then subsection C is the peer-to-peer. And then in D, there's language that applies to both. So first in subsection B, to the extent funds are available, a public school may apply to the Department of Mental Health or designee for a grant to provide mental health literacy training to educators or other school personnel. Mental health literacy training shall include topics related to working with youth in an educational setting, such as information about mental health conditions and symptoms, understanding common youth mental health and substance use challenges, reducing stigma and promoting supportive school environments, strengthening protective factors and help-seeking behaviors, recognizing risk factors and warning signs, responding to students with empathy and appropriate boundaries, information about mental health treatments, and accessing mental health resources or services throughout the state. This section shouldn't be interpreted to require the adoption of a particular curriculum or instructional content. So that is the mental health literacy for aimed at adults working in school. Second programming piece is the peer-to-peer mental health support.
This looks a lot like what we did with the ERA. We also had the support for teachers and staff. So I had to go back and look at what was in that bill and how the money was spent. We have to figure out how the money was spent, that and what the outcomes were. So we might be able to integrate some.
What's that?
It's the ERAS funding. AIRFE. Education funding from the pandemic. You know, like ARPA.
Yeah.
ARPA funding education.
Got it. So it was federal money.
Federal dollars. And I found $3 million that I could start funding and use for that program. We might learn something from how that went.
I have to remember where that was. Now that you're saying it, I remember.
Exactly.
I remember you working on it, but I'm not sure where it landed. So
I was in this room.
Yeah,
And I worked with Brian Campion in the exact room.
it was in a bill, I thought that was here.
Yes, it was.
Um,
So we'll have to move back.
okay,
Because it really does, it does have some fundamental.
yeah, I'll have to go back and see what I got to dig up.
And I did want it to continue. But,
Okay. So the next piece is the peer-to-peer piece. A school, an after-school program, or a youth mentoring agency may establish a peer-to-peer mental health program that provides structured opportunities for student-to-peer connection in a supervised school or after-school setting. It's overseen by an adult who is not required to be a licensed, qualified, or rostered mental health professional, and emphasizes school and community-based resources and how to access professional services when additional support is needed.
this is very simple.
DMH is to provide oversight and guidance to any school, after-school program, or youth mentoring agency seeking to establish or maintain peer-to-peer mental health programs pursuant to the subsection and qualifications of the adult overseeing the peer-to-peer program. In subdivision 3, peer-to-peer program that is established pursuant to the subsection is to be supportive and non-clinical. It is not to replace mental health services provided by a professional. Subsection D, this pertains to developmentally appropriate guidance. So this is for both of the two pieces, the two programming pieces in B and C that we just looked at. So for any mental health literacy, subsection B, or peer-to-peer support program, subsection C, established pursuant to this section, DMH is to develop age-appropriate guidance for elementary school age youth that emphasizes social and emotional development, peer connection, and strengthening protective factors. And for middle and high school age youth, that emphasizes protective factors, reducing stigma, and supporting students in recognizing and appropriately responding to risk factors and warning signs associated with mental health and substance use challenges, including co-occurring challenges. And then guidance. So there is language that DMH is to provide guidance. So DMH wanted to clarify that guidance means defining and disseminating best practices in a written format. So that is the form of the guidance at the end. And then there's a report back each year on January 15th. DMH is to submit a written report to the policy committees evaluating the effectiveness of programming established pursuant to the section, including aggregated info on the number of schools, after-school programs, and youth mentoring agencies requesting and receiving the department's support, the number of students, educators, and school personnel participating in programming, and findings and recommendations regarding the two programming. That's it.
Okay. It just needs money. So why don't we look at what has happened with the funding that we did have? This would be DMH and AOE, was AOE money, and then we linked up Department of Mental Health. And now we have this wonderful substance misuse prevention. Fund. So. Yes.
Thank you, Chair. I have a question. I think for some reason, an earlier bill kept coming into my mind, which was the one about mandatory reporting and I guess as I'm thinking about like peer-to-peer mental health things happening and concerned about mandatory reporting. But maybe this bill doesn't get specific enough to me.
I'm not your expert on mandatory reporting, but I would imagine a peer is not a person who's a mandatory reporter.
Okay.
To the extent an adult working in the school learns something that would require mandatory reporting, I assume they already have that obligation. This doesn't specify that the program would be operated by a teacher. In fact, it says somebody, that's something that's going to be decided at a later date. So I think it is a little bit open-ended friendly. I'm looking at mental health bills from the 21-22 biennium just to see if anything jumps out with estimate. Oh, there's so many.
I mean, we get the YRBS every 2 years. Right, so,
Yes.
so we get the information from those.
I think I found it on my first try.
Oh, wow.
Well, let's see. So this is, right here it says 2022 at 112. So you had this inventory, mental health crisis response inventory. What I think you're interested in is this provision of mental health and well-being supports for educators. Does that sound right?
Yes.
Fiscal year 23 AOE application of DMH shall contract with one or more organizations to provide statewide COVID-19 recovery supports for educators and school staff. Support shall provide mental health clinicians and focused on COVID-19 recovery, including wellness, trauma responsive school practice supports, statewide regional supervisory union. This support. Oh, this part.
Yeah,
Grants to expand mental health and well-being services to youth. Fiscal year 23 AOE with DMH shall work to establish a 2-year program utilizing a tiered support approach to ensure continuous support to children and youth in a variety of settings, including supervisory union and district-wide in-school community technical education centers after school by providing grants to expand existing school-based counseling services in underserved districts developing their school-based or community-based after-school programs, operating in a variety of settings outside the school day and over the summer, etc. That support mental health and wellness needs of students, families, and staff. So that was a 2-year program. It was not necessarily peer-to-peer, but it could have included peer-to-peer.
Yeah, it wasn't at all. I mean, there was grants, really,
Yeah.
applying for funds.
Then you had mandatory eligibility criteria. The applicant had to collect data, demonstrate effectiveness. Applicant meet student needs by incorporating multi-tiered system of supports. Whole child, whole school, whole community model for strengthening families, youth thrive program. Additional eligibility, the applicant works in close partnership with classroom teachers, school guidance counselors. Applicant uses specially trained staff to provide one-on-one and small group supports. Applicant provides participating families with assistance in navigating behavioral health resources. Applicant provides opportunities for children and youth to participate in activities.
Mental health first aid, they were wonderful.
First aid. You received a report this January.
Did we?
I don't know. Summarizing the programs to which grants were awarded. This was a June, this was the Agency of Education. Should have come in around January 15th. And it would have been something like mental health grants, mental health after school programming. Are you? Okay, I can. Yeah.
That'd be good to know. Might be something you could add. And there was funding with this. Question is, what were the outcomes? How was the funding used? And that will help us make a determination of maybe some things we can add into this with them. The substance misuse prevention fund is all you stuff this year. Yeah, right.
Going back to December to see. That from the Agency of Education. Any reports for this session?
Would it be in the education already?
I'm looking at the website, the Find Legislative Reports function, and I'm searching by AOE, and I'm not.
I think we should ask them for that.
So it's, so you know what to ask for. It's, Act 112 of 2022. And it's the report required by section 3. D.
Was there any report on the first section on the staff, educators?
I will, but you might want to copy DMH on that email request until they're jointly submitting it. Let's see. No. No, I'm not seeing a report. Oh, I'm sorry, yes, I see. I remember that it's new. And then you had appropriation, you had 500,000 for section 2, and you had 2.5 million for section 3.
Right, so, right, I remember it was total of 3. So that would be good to know. And there were a lot of organizations very interested in working on this, including the Medical Society, the NEA, the AOE is very excited about it. You're multi-charity partnership. Good. All right, thank you for looking at it.
I know, well, I'm impressed that it popped up so easily. That doesn't always happen.
So good, so let's, we don't have a whole load of time, but this continues to be a significant issue. This, the mental health needs for kids is huge. we'll try and look at it. As much as we can over the next couple of weeks, and maybe we can put something in else.
And we hear from the AOE. We have time to hear from the AOE.
Well, they are being a little bit later. We talked about budget. They asked if. They remember Act 112 of 2022. You might give them a chance. Yeah. This will be there.
I'm just wondering how this will. What it will look like in practice.
Well, this is it's very sort of general.
Right.
And if there's money available, then people can apply for the funds and define the program that they have. So, and that's okay, but you need to have somebody guiding it. You need to have direction, somebody in charge. There's a couple of things missing. It's a good idea. That would be to be. We have to make that trouble from certain diagrams. Yeah, but we do need to have diagrams to be sure. Okay, so let's, is that okay with you folks if we look at that, come back and look at that one? It's a pretty nebulous bill right now. But maybe there's some things we can do to use data from the previous work and put some guardrails or something. Okay. All right, so we're on to H816, which is the artificial intelligence. Missions of mental health services. Can you help us where we are right now? I know there's a lot of work that's been going on inside.
Yeah,
Around all this.
yeah, so this is a new draft. I'm happy to walk you through it. There have, been some meetings with various stakeholders, this language was proposed to you and I was asked to draft it up, so that's what we're looking at
We may
today.
as well take that step.
So we have our changes highlighted in yellow, and this is changes from the, House version. You know, when I mark up the changes, what it doesn't catch is the strike throughs, so there were more sections. Now, what you have is that it's the purpose of this act to safeguard individuals seeking mental health services in Vermont from psychological harm, including death by suicide, by ensuring that these services are delivered by mental health professionals and not independently by artificial intelligence systems. You have the same section 2 that you previously had with regard to unprofessional conduct. And this says, for any mental health professional, misuse of artificial intelligence would be grounds for unprofessional conduct. Section 3 is a section that was in the previous bill. This is in Title 18. And this is prohibited uses of artificial intelligence. We have a definition of artificial intelligence. It no longer has a language defining generative artificial intelligence. And then a definition of mental health services to mean counseling, therapy, or psychotherapy services used to diagnose or treat individuals' mental or behavioral health or provide ongoing recovery support, including providing therapeutic decisions, issuing direct therapeutic communications, generating treatment plans or recommendations, or detecting or interpreting emotion and emotional or mental states. Mental health professionals, the same as we had previously, that was quite extensive. And then we have a definition of what is meant by therapeutic communication. You remember, therapeutic communication is one of the therapeutic communication is one of the types of mental health services, and we also have a definition of therapeutic decisions. So therapeutic communication means a written, verbal, or nonverbal interaction intended to diagnose or treat any type of mental or behavioral health concern, including ongoing recovery support, or provide any advice related to diagnosis, treatment, or recovery, such as engaging in direct interactions with clients and patients for the purpose of understanding or reflecting the client's and patient's thoughts, providing guidance, therapeutic strategies, or interventions designed to achieve mental health outcomes, offering emotional support, reassurance, or empathy in response to emotional or psychological distress, collaborating with a patient or client to develop or modify treatment plans and therapeutic goals, delivering feedback intended to promote growth or address mental health outcomes. And then a definition of therapeutic decision. This is from the underlying House bill, but it means the final clinical determination regarding diagnosis or the selection, modification, or termination of treatment or care. It does not include algorithmic risk scoring, data analytics, or other clinical decision support tools when used under the supervision of a licensed mental health professional. I wonder if we just want to say mental health professional. Probably because they're licensed and certified, and your definition includes non-licensed and non-certified.
Yeah, so
Let me mark that. Mark it out for myself. Oh, I didn't get this version. Okay, I will remember. So next you have a consolidated version of the concept that was in the House bill, which is that an individual, corporation, or other entity shall not offer or provide mental health services through AI without the involvement of a mental health professional. And then you have this language that you looked at earlier in the context of the baby food bill, which is that a violation of this section shall be deemed a violation of the Consumer Protection Act. I would guess that the AG's office might make the same recommendation of removing this language. So if you'd like to do that, I'm happy to do that. And this language, unlike the version that came over from the House, does have a civil penalty of $10,000. If you remember, there were two versions of this AI bill moving. So one version had this penalty, another version did not. So this pulls the civil penalty in from the other version.
When you say the two versions, like the Senate version and the House version.
Well, the Senate version is also in the House. So you're going to ask me for the
Oh, I
numbers.
got it.
Yeah.
So there were two House
644.
There are two House versions and one Senate. So the Senate
640.
version was not the version that moved in the House, if that's helpful.
Yeah.
Page 6. Nothing in this section is construed to preclude or supplant any other statutory or common law remedies. And then in subsection D, nothing in this section shall preclude a mental health professional who is operating within the professional scope of practice from utilizing AI tools that are compliant with HIPAA or authorized by the FDA, provided that the mental health professional reviews and approves any therapeutic communication or therapeutic decision. And then there's language in the House bill that is omitted from this draft. There's a whole section that regulates the practice of mental health professionals with regard to the use of AI. And this subsection B sort of replaces that. So what is no longer in the bill is sort of the specificity around which type of AI tools can be used by a mental health professional and when and how AI tools cannot be used by a mental health professional. Instead, you just have this language that mental health professionals can use AI tools when the tools are compliant with HIPAA and authorized by the U.S. Food and Drug Administration. Wondering why the Food and Drug Administration.
Oh, I
I remember
understand.
where that language came from. I'll have to double check where that came from. That just jumps out to me. Why would it be? I'm not sure.
maybe it's because of.
I'm wondering. Where I got that language from. I'm gonna go back and double check that.
Okay.
And then there's this new reporting section, which is that by January 15 of 27, OPR and the Board of Medical Practice are to jointly submit a written report to the various policy committees containing recommendations for the regulation of the use of AI by regulated professionals, including recommendations for legislative action. You remember when OPR was here, they shared some concerns about only regulating AI with regard to mental health professionals, because it sort of suggested that the inappropriate use of AI and other efforts wasn't unprofessional conduct. So this report is an attempt, I would imagine, to get a better sense from OPR about what kind of regulation might be required for other professions with regard to AI. So different from the last time you've seen it. No question, I just said it was different from the last time you've seen it.
That's it, questions. So what I think. We have lots of time. Which is wonderful. So it might be useful, given the amount of work that is actually happening on this bill. If we could go through the bill with an eye to understanding and marking up and asking questions with some specificity. If we have the luxury of time, unbelievable.
I can be here saying,
Yeah.
when I, this draft of this bill that was in the Senate side, that was also apparently in the side. The goal for me anyway was just to sort of put a prohibition on chatbots delivering mental health services to people. I'm hoping that is what all of this language is getting to.
Does it get to that? Because I think that is.
That's what the subsection B is trying to do.
I just want to make sure that that's the main thrust of the bill.
The only people going out getting their mental health.
Okay,
So let's.
do you want me to sort of go through it again more slowly or?
Sure. To finish your.
No, I mean, you did a good run through, but obviously there's more than just that one provision, so I just want to make sure that everyone's.
Yeah. Sort of, there are lots of other provisions, but this subsection B this is the substance of what the bill does. You have a purpose section, you have effective dates, you have a penalty, you have language that mental health professionals can use AI within their scope of practice if it doesn't violate HIPAA, but the real sort of thrust of what the bill does is it says that no one, including a corporation or other entity, can offer or provide mental health services using AI without the involvement of a mental health professional.
Great, and I want to make sure that, I know Jess is here, but that the healthcare world is okay with this because they do use AI and,
So why don't we do this, why don't we just turn to Jessica right away? And I know you're seeing this baby for the first time, this new language. I don't know if you want a preliminary comment, but what we were gonna do right now is to go through the bill slowly and to ask questions and to clarify language on the bill that Katie just presented. So we can hold off asking that question until we get to that section. Okay, let's do that. Because it's a really good. Wait, oh, shoot, okay.
I'll be back.
Let's take a break. Okay. Till 5 after 11.
Minute break.
And Callista, we're gonna block live for 5 minutes. Okay, we'll come back. So I'm just having a chance to.
That OPA language.
I just sent out.
Okay, I don't get that.